My name is Paul Mohabir. I'm a clinical professor of medicine here at Stanford University. I'm one of the directors of the intensive care units, and I'm also the director of the adult cystic fibrosis program. I've held this title for about 22, 23 years, so I'd say that I have quite a significant amount of knowledge in understanding the trajectory of CF, the disease, the people, and really the outcomes. And also, my forte is really exploring options of outcomes and analyzing really large databases. We've written a few papers about hemoptysis. I love this topic. It's an important topic. And unfortunately, this disease or these syndromes or this episode continues to occur in our CF patients. So my focus today will specifically be about hemoptysis. Let's start off with the basic definition. We're talking about, in very simple layman terms, someone who coughs up blood. And it's essentially the expectoration of a large amount of blood and a rapid rate of hemorrhage. We have to be prescriptive to understand when to act, when to behave quickly and do things, or to conservatively watch. So many authors have really explored an overall definition, and the working world definition right now is massive hemoptysis is defined as acute hemorrhage, bleeding from the mouth, presumably from the lungs, at greater than 240 cc's of blood over a 24-hour period. If you liken that to a Dixie cup or a full cup drinking cup, that's approximately 240 cc's. We are not talking about blood plus sputum. We're talking about isolated blood. But there's another definition. Not all individuals in CF patients will have bleeding all at once. And we can also explore massive hemoptysis as a definition of recurrent bleeding or hemorrhage from the mouth of greater than 100 cc's per day over 3 to 7 days. So we have this recurrent amount of bleeding that is large enough and frightful enough, but not the large volumes we've talked about. Both of these categories at least establish and meet the diagnosis of a massive hemoptysis. This is an important topic because if we think about this, coughing up a lot of blood is scary. But also, think about it. Blood pooling in the lung can cause asphyxiation, low oxygen levels. They can obstruct the airway. And of course, if we bleed out enough blood, we can have significant low blood pressure, hypotension, and shock. And of course, common sense would dictate we would be quite anemic, requiring blood transfusion. The other thing that can happen is a lot of blood going into the lung can cause what we call a pneumonitis, a very profound inflammation of the lung, and of course, triggering these bad bugs that are known within CF patients and causing an exacerbation. So there is a cascade of many things. They can happen all together on their own, and it can also be quite dramatic. And in some cases, the amount of bleeding could exceed the ability to recover patients and lead to demise. Now, this is important because when you're calling your CF center to talk about this, massive hemoptysis is clean and simple. You're going to the emergency room, call 911. Now, the problem that arises is when patients have a little bit of blood. What do you do? This is an important time to speak to your coordinator. They will speak to the CF physician and deliberate. Do you need to come into the hospital? Do you need antibiotics? What's the next step? Or do we conservatively watch? But of course, the main take-home point here is when in doubt, you have no idea, present yourself to either 911 call or to the emergency department. But the next element is important. We're really not quite sure what the true diagnosis of massive hemorrhage is. I did mention 250 cc's over a 24-hour period or greater than 100 cc's over a couple of days meets the criteria, but that's a global understanding. It's hard for me to get a call from a patient and said, I've coughed up 100 cc's in 24 hours and for me not to be alarmed. So there are many papers here that outline 100 cc's, 200 cc's. Many papers describe what massive hemoptysis is. Ultimately, your goal is to call your doctor to figure out what you should do because I'm not looking for someone at home to wait for them to have 250 cc's or 240 cc's before they act on it. So this is the importance of this talk is to really create a union between the patient and the physician or the treatment team to really talk about this and figure out a great plan for everyone moving forward. Now, understanding the blood supply is crucial here. There are two blood supplies going to the lungs, and the duality of this blood supply is important. There's a very large artery called the pulmonary artery. It's a big artery leaving the right, directly out of the right side of the heart. Now, I want you to understand this blood leaving there does not have oxygen yet because it hasn't really gone through the lungs yet. So it's deoxygenated blood. And this pressure system that it's going through is under a low systemic pressure system, as opposed to thinking about the bronchial arteries. And I'm going to outline that in just a second. But the other tree that supplies the lungs is the bronchial arteries. Now, this blood has already been oxygenated, but the amount of blood only accounts for about less than 1% of the circulation which we have in the entire body. And it's under systemic pressure. So that means the pressures are higher in this bronchial tree. You'll understand in just a second, higher pressures could lead to higher bleeding. If you draw your attention to the right of the screen, what you'll see is this red curvature here. We're talking about the main aorta as it leaves the heart. What is important is we have the aortic arch, and as we move down, you'll see the bronchial arteries. The majority of the bleeding is going to come from this territory. These small little vessels that arise on the right and the left of the aorta. And it is these very friable, timid, easy to rupture vessels that under this higher pressure that I mentioned before that are the ones that lead to the massive destruction and big issues with hemoptysis. Now, I also talked about the main pulmonary artery. The main pulmonary is a large artery, not as much systemic flow, but if that were to rupture coming directly from the heart, it usually leads into devastation. It's not the common one that we see that's bleeding. It's usually the small, friable ones, the bronchial arteries, that become inflamed. Now, it's interesting. Below the bronchial arteries, you're going to see a whole bunch of other little vessels extending to the left and the right. This is important. These vessels, these small vessels here, or arteries coming off the aorta, they supply the intercostal, the spaces between the kind of the costal muscles here in the ribs here, and they go directly into the chest wall. This is going to come back to be very important later because we're going to talk a lot about the bronchial arteries and their bleeding, but we must note that these other vessels are also there, traveling not necessarily directly onto the lung tissue, but close enough to, and are also prone to inflammation and also prone to bleeding. So we need to understand this anatomy as we figure out what to do with this patient population, particularly when there is significant bleeding. Now, here is a kind of a better and detailed look at this. And this is taken from a great author by the name of Netter and has a textbook. It's kind of the gold standard anatomy textbook that all of us used in our training. But what you'll see there to the left, we see the pulmonary artery. This is coming directly from the right side of the heart, and you'll see how it's tracking down. This yellow marks the lungs. These are the airways coming down to the very, very smallest portion. This is the alveoli. This is the most important unit of the lung at the bottom, this grape-like look, and this is where gas exchange occurs. But I want you to track this little itty-bitty artery here, this red. This is the bronchial artery. These are the ones we're talking about, very closely associated with the bronchial tree. And as we come down further, you can see these little itty-bitty vessels here that are a problem. So if we think about this, we have the distal alveolar units. These are the lung units. Should they get inflamed? If anything happens here, look how close these vessels are to them, that they're certainly going to be transferring some type of inflammation to these vessels. So makes them a higher potential of being bothered by inflammation. So this is a summary of what I've talked about. The majority of the bleeding comes from the bronchial artery supply, which is systemic, as I mentioned, higher pressures here. As I mentioned earlier, that if one were to bleed from the pulmonary artery, it would be devastation. Interestingly enough, 2/3 come from the ventral aorta. What does that mean? It means the area of the bronchial arteries I talked about. But we must be mindful of that other 1/3 that arise from other variable locations, for which I mentioned the chest wall, in between the ribs. So it's not always directly in the lungs. It might actually be related to other areas. So we have to be mindful of this and we have to investigate that. Some of these non-bronchial arteries are listed here. The phrenic, which is a nerve that innervates the diaphragm to move up and down. You wouldn't think this would be affected, but it is prone to bleeding. The intercostal, the area between the ribs. There are multiple other arteries there that we have to think about. And what is interesting is these other vessels, they just don't only, they're not just present. When patients get inflamed, these vessels, let's say the bronchial artery, sometimes start to get tortuous and they bind to other vessels and cause them to inflame. So we can get this, what is called collateralization, where they can be collateral, they bind, and then you have a meshwork of inflammation to other arteries that were not initially the bronchial arteries that are at risk for bleeding. One of the other things that happens is if you have inflammation in the alveoli and they kind of erode, if you will, or go towards these bronchial arteries, these arteries get large. They get large and inflamed. They get friable. They become susceptible to rupture. And one of the things we tend to look is something called tortuous, where they get so large and they just kind of start rolling and kind of engrafting on each other that it's noticeable when we do certain tests to figure this out. One of these tests is called an embolization or bronchial artery CAT scans, and we're going to talk about just a moment. This chronic inflammation that we see contributes to what I said, this hypertrophy or this enlargement of these bronchial arteries. And there's a term there called angiogenesis. Now, this is an interesting term. Our body and our vessels are just a phenomenal system that when we see or the body sees that there's disruption, inflammation, the body's pretty smart. It actually starts to produce new vessels, angiogenesis, the new development of new arteries and vessels. Now, as you can imagine, they're not the original strength and the integrity that we were born with, so they're weaker. They're thinner. And of course, the thinner you are, the more prone to inflammation. So we have to be thoughtful that yes, the body's creating this wonderful system to create blood flow, but it also puts you at risk as well. And then lastly, the hypervascularity and the parenchymal damage with has a propensity towards hemorrhage. So just if you think about it, we have lung tissue that has been affected with cystic and fibrosis scarring that in itself is disrupted tissue. That in itself can bleed just because of being of poor quality and integrity. So if we draw our attention to this image on the right, which was created specifically for this talk, I want you to understand the blood vessels here. And we see this is the main bronchial tree coming here, trachea, branching into the right lung and the left lung. But what I'm showing you here is these vessels. You can see they become weakened, thin. And what you're seeing is when that disrupts, we tend to have some amount of bleeding here. Our problem we need to be mindful of is, well, how do you stop this? And we're going to talk about how do you stop when the CAT scan looks at this and we send a dye and we see these vessels and then we see blood blushing into the tissue or the area that tells you that this vessel has no integrity, that it's burst. So the blush that we see shows that blood has removed itself from the vessel, and that becomes the target area where we have to go in and stop that blood supply. And what does that mean? We're going to get to this embolization, where we send a coil and we get to this area and it just shoots off and it just blocks this area off. Now, we have lots of other blood supply in the lungs. So it's not to say that we are going to kill off the lung. And also remember, I told you, we also have the pulmonary artery that's constantly supplying lungs. So we do have good blood supply, but we have to stop these micro areas of bleeding. Let's get to the evidence. Now, these are older papers, but they're very powerful overall. I want to be the one theme that's going to come up is a lot of things that are happening were pre-modulator, pre-corrector era. And this is important because it leads us to think about, well, what is the innovation? What's happening now? One of the papers that's been cited quite often in 2008 is by Efrati and colleagues and really reported, and it was CF patients, Israeli population, that 9.1% of all CF patients, again, Israeli patients, would have an episode of hemoptysis. And this was analyzed over a 5-year period. That's a large number, almost 1/10 of the population. Now, we didn't define what type of hemoptysis, but what they found in their small paper is that majority were scant to moderate. So you're bleeding, but they didn't make it to the massive bleeding. And you can see the number here, 1 year of 4.1% that actually had massive hemoptysis in their lifetime. Now, they also found that the majority, 60 to 70%, were over the age of 18, and it is associated with disease progression, which would make sense. You know, it took time, during this period where we didn't really have great modulator therapy, patients were progressing, and by the time they got 18, they had pretty bad advanced lung disease and they were higher risk. But they also found, interestingly, their risk increased in time. So there was a 1% yearly incident in age between 16 to 20. And the most precipitating factor was the exacerbation of pulmonary infection. As I talked about, it is thought that this is related to overwhelming inflammation and recurrent attacks in the area that led to this, what we call kind of transmigration of inflammation from the alveoli into the bronchial wall, and then led that to become abnormal. Now, this is old data. The US prevalence was about 0.797 per 10,000 patients. The data has changed significantly moving forward, and it was very similar data in the European prevalence as well. Now, this is the most cited paper. It's by Patrick Flume back in 2005. Now, again, pre-modulator era, but it gave us an idea of how often were patients having hemoptysis during this period, and even more so, how often were they having recurrent hemoptysis. So it is not a one-time thing. Dr. Flume and his colleagues presented back in 2005. They looked at the Cystic Fibrosis Foundation patient registry, pulled the data at that time, and looked at a number of patients. And they really looked at episodes per year per patient. So what they were curious about is the number of patients who had hemoptysis 1 during this period. They found was 858 patients out of 1,153 total that had hemoptysis. But what's important is that 206 number. So of that total, 206 patients of that 1,153 patients had a second episode of hemoptysis. And that was defined as massive hemoptysis with the same criteria we've used of greater than 240 cc's. And as you go down, yes, it's not as much of a third episodes, but what is important is that just because you've had one, it's possible and rare that you could have seven, but it does become more possible and probable that you could have a second episode and or a third episode. So it speaks to the friability, the nature of the lungs, and how susceptible they are to having damage again. The slide I created, this was based on the 2005 paper by Flume and colleagues, but it was just getting an idea of when did it happen? What were the years? The green line here, triangle, you can see, just talks about the percent of patients with massive hemoptysis. Now, this was back in 2005. You can see less than 20% were having this occur less than the age of 20. So that was 16 to 20. But let's just go to what's more important. The pink zone. So above the age of 80, you can see 80% of patients who are, sorry, above the age of 30, you can see that 80% of these patients had massive hemoptysis. So increasing age did correlate with the notion of having an episode of their first massive hemoptysis. Back in the days when they did the paper, they looked at some of the things that were noted in these patients who were having massive hemoptysis. And just to understand a bit of statistics, when we talk about a p-value, it's just the probability of, is it by chance that it's just random happening, or it talks about, did this really meet a probability that likely was really happening, not by chance? And anything less than 0.01 tells you a p-value of less than 0.01 indicates it's not by chance and randomness. It really was a noted factor that was correlating with this. So what they noticed is back in the day when they did the study that if you had Pseudomonas, Burkholderia cepacia, and Staph aureus, those patients were higher risk of having massive hemoptysis. So they noted that in the population. They also noted, importantly, what I've been talking about is an FEV1 less than 30% correlated with having an episode of massive hemoptysis. Intuitive, and it makes sense. If you have worsening lungs, the sicker the lungs, the increasing risk of bleeding. And they also found that patients with tube feeds. Now, to me, that makes sense. Patients who are usually sicker required worsening lungs, worsening body mass index, and required tube feeds. So that notion makes sense. Liver disease was also noted, which speaks to how, another organ is in trouble. And they had talked a little bit about patients who are using pulmozyme, which is alpha dornase, and inhaled tobramycin, but I think the correlation has not held true over time, so I don't want to spend too much talking about that. In 2005, what did this all mean? So we had hemoptysis, we're trying to fix it. We've talked about embolization and getting in there and stopping the bleeding. But even with that, bleeding of the lungs is a big deal. And it does hold a mortality that we need to talk about, and we cannot ignore it. What this paper described is if we only looked at individuals with their first year of their years following their first massive hemoptysis. So massive hemoptysis occurred here at point zero. And what they found is if you look at within that first 18 months, less than 2 years, 20% had passed away by that time. Now, this is an old paper, pre-modulator. And then you can see by the time 10 years after the first episode of hemoptysis, the amount surviving is only about 38%. So this speaks to two things, that hemoptysis does correlate with mortality, increasing mortality, but it was also in a different era. So it's serious, but there are things that have changed right now, and that's what we're going to be focusing on next. So the summation of multiple papers suggests that about one-third of patients back in the day who had one episode of massive hemoptysis would pass away within the first year. If you were hospitalized, there was a significant mortality from 9 to 13%. Makes sense. You were sick enough that required hospitalization. It could end up not so well. And overall, based on multiple papers, kind of the mortality overall through time in patients who had an episode of massive hemoptysis had a 30-50% chance of passing away. They also found that blood transfusions were a predictor of mortality, and that makes sense. You bled so much that you required us to give a transfusion. That speaks to the intensity of the pressure of the bleeding and the higher risk of passing away. Now, that's interesting. But interestingly enough, there are some papers, particularly a recent Israeli study by Efrati and colleagues, which we spoke about previously, did not find a mortality in the hemoptysis group. And I think that's interesting. But also, I did mention they only had 4.1% of patients who had true massive hemoptysis. So it was a small single center trial. It had a small amount of massive hemoptysis during that group. So it's hard to compare when we have national registry data. Again, emphasizing these are very old papers. So let's get back to the important mainstay of therapy, the treatment of choice for massive hemoptysis or patients who have been bleeding, not necessarily massive, and we need to do an intervention. There's not much to offer, but this particular therapy. The initial cases were back in the 1970s by Remy and colleagues, and they published data that, hey, if we can actually send a contrast dye into this lung, see where the dye is going, and if we see a blush or coming outside the vessel, then let's send something in there, a coil, something to block off that area. So proof of concept worked, and they started really talking and doing these on case by case basis. It was effective and it was safe, and it worked. There were actually some great papers that were published really talking about, well, what if is it successful? How great are we? This paper, particularly that was published, it's kind of earlier overall in 1990s, they said that their first success rate of the first time a bronchial artery embolization was 75%. So that stopped the bleeding. And these, of course, are people with recurrent bleeding. If you did a second bronchial artery embolization, which is like, well, now we're talking about a problem, we're bleeding again, it's almost 90% success rate. And of course, if you had the third one, almost 93% success rate. The recurrence rate we know is, I've talked about this already. If you bleed, you're going to bleed. But this is now talking about recurrence rate in patients now who are being embolized. It can be 38 to 46%. So we really want to get in there, do an intervention to stop the recurrence and reduce the potential for mortality. They also showed some good data, the mean time for recurrence. So when did patients re-bleed or within 12 months? And I also mentioned earlier that 75% of the bleed was from bleeding was from the non-bronchial arteries after a bronchial artery embolization. So let's talk about that. When one does this procedure, we hope to see a blush, as I mentioned, an area of the vessel that looks like it's bleeding. Unfortunately, the ability to see this is really dictated on a patient actively bleeding in front of you. That's usually not the case. The blood vessel bleeds, it spasms, and then we don't see bleeding. In our center here, we published, and I'll show about my publication, that not one patient had a CT that showed the blush. So what do? You work with your interventional radiologist and you have them target areas that look large, tortuous, culprit areas. And as I mentioned, the culprit would be those initial bronchial arteries. And sometimes they just need to take them all out, embolize them, stop all of them from the potential bleeding. But as I mentioned, we start wondering if you've done that and someone bleeds again, where are they bleeding from? And I told you that if we had a whole 1/3 of bleeding that's coming from the intercostal muscles, mediastinal muscles, the phrenic area. So this is where it gets sophisticated that in someone who has recurrent hemorrhage, and if you've taken out or embolized the large bronchial arteries we've talked about, then they have to be sophisticated enough to attack the other zones. And this is where a specialty center is very crucial and paramount to knowing these other vessels and having the know-how to say, we need to attack those. I want to add one other caveat. I mentioned the word angiogenesis before. I said that the body is crazy. The wonderful is that if we have inflammation in these vessels, then we start making new, immature, young vessels. Well, that can be a problem because those vessels are so friable and young and they don't have that strong integrity that you may have embolized off the large bronchial arteries, but you have new collateral angiogenesis happening. So you might come in there, they bleed again and start attacking and trying to get all the other arteries, but you might have to also go back to those bronchioles and look to see if there are new branches coming from them. So now we're getting in a world that's very refined and chiseled therapy that makes the thought process more difficult as you're moving on with recurrent hemoptysis. This is the paper we looked at. We looked at 17-year review here, and we did this here at Stanford with our CF patients, and really looked at how did people do with bronchial artery embolization for hemoptysis. And we had 28 patients, which seems like a small number, but really it's a large number of patients. This was with CF. So we still have a lot of bronchial artery embolization from other things. So we talked about 28 patients who underwent the bronchial artery embolization, which is BAE. One of the patients, just to understand how they did, passed away because the BAE was unsuccessful and they passed away within 2 hours. And I was present for that. So that is someone that just hemorrhaged to the point that we know there was high mortality. You can see 20 of these had a single successful bronchial artery embolization. And of the 28, 7 who required repeat bronchial artery embolizations within various time periods. Some of them repeated within 3 years, some within 44 days. So there's a variability in the repeat requiring the bronchial artery embolization. We decided to explore, well, what did it mean for those who passed away? Were there anything that we could learn from those? So patient 1, he passed away within 18 days from respiratory failure. Really speaking to what I talked about before, asphyxiation, blood in the lungs, hard to recover. And these patients already had a lower FEV1. One patient was done here but passed away from an outside center. The other patient, number 3, had massive hemoptysis again, so exsanguinated or blood out. And then we can see some had clots and a lot of them had respiratory failure. If we think about this, it makes sense. You're bleeding out the mouth, but also a lot of blood in the lungs, and we're just not able to oxygenate. So the paper we put out here was beautiful in the sense that it supports what we know. Luckily, very luckily, it's a small number of patients that move to this level of progressive badness here. So we were pleased with the result. This is an important paper that has actually recently been published in 2025, and they looked at the long-term outcomes following embolization of the bronchial and non-bronchial systemic arteries for the management of hemoptysis. This too was a 20-year experience, but really talked about how did patients do long-term, which is the definitive therapy here. To get an idea, I said hemoptysis comes from a lot of sources. What I want you to take home is CF. You'll see it down on the left side. There were only 3 patients that they were able to analyze, so only 2.3% of the population. And that's important because CF is not the most common. So the wisdom The story behind this is the wisdom that these interventionalists are seeing is they're not just working on 28 patients like we did in our study. There are many, 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 111 patients that were done in that 20-year study that they were able to understand all types of patients, all type of causes of bleeding, and how do you do a procedure effectively. Again, the pathophysiology is different for CF. Let's follow the results here. So with the CF patients, what we learned is the risk associated with current hemoptysis. I thought this was great to look at in this after successful embolization at a large center here, and that was a 20-year review. They found that only 7.7% of patients had a recurrence, and that was notable in the CF patients. So the two patients, what we learned from this paper is cystic fibrosis is at risk for recurrence, which I told you it's a constant inflammation, and patients who have an aspergilloma, excuse me, which is a fungus ball here. This paper also talked about, well, how did these patients do as far as cumulative hemoptysis control rates? Was it under control over time? And you can see over time, there is certainly recurrence as the time in months goes on. The amount of hemoptysis rates go down, but it's still present over multiple months. And then the last paper I really want, this was just recently published, and this is important because Christopher Goss, who was the author of the 2005 paper that I talked about, the initial incident hemoptysis, talked about what if you had hemoptysis? What does that mean, whether you've had bronchial embolization or not? Is that put you at risk for lung transplant or death without transplant in CF patients within the US? Fantastic paper. I want to outline that this paper occurred in 2016, pre-modulator era. And what they said is, well, if you've had one of these episodes of hemoptysis, Eve, of any hemoptysis, what does it mean? So this first table really is an outcome of hemoptysis or death on death without transplant or with needing a lung transplant in individuals with CF. Well, what I want to really talk about is if we work down to hemoptysis where it says massive here, we can see there was a significant amount of massive hemoptysis that was present here. One episode, greater than two episodes. So 8.7% of patients had a significant episode of hemoptysis in the cohort overall. And we were just understanding how prevalent this was. But let's talk about what that means as it relates to getting a lung transplant or death without a lung transplant. This is something referred to as statistical analysis, which is as odds ratio. So what are the odds? You're 2 times more likely to die, 3 times more likely. And again, p-value means we're going to look at this. If it's less than 0.01, it means it's not by chance. It's meaningful, and it really does relate cause and effect. Let's talk about massive. If someone had massive hemoptysis, their odds of either dying or needing a transplant at some point within this study was sixfold, 6.3 times the risk of somebody who did not have hemoptysis and had a p-value of less than 0.01, means it is significant. Interestingly, if you had massive hemoptysis and you already had advanced lung disease, as I told you, the risk factor, you had a 3.8 times increased chance of dying compared to those who did not have hemoptysis. Now, I apologize. What I want to show on this slide, this unadjusted rate, is this gets very sophisticated because what it's telling, if I take out all these other things, Pseudomonas, if I don't want to analyze that, everything, and I control and I say, let's assume they're all equal, the real important analysis here is that massive hemoptysis and massive hemoptysis with hemoptysis with advanced lung disease, they are 1 to 2 times risk. So what we want to take home here is if you've had hemoptysis, you're at risk for either passing away or needing a transplant. Pre-modulator era. So keep that in mind. So their conclusion is hemoptysis for all cause, massive hemoptysis, and advanced lung disease is that we saw an association with increased risk of transplant or death without transplant. And again, my emphasis is really important here. This is the pre-highly effective modulator era. Now, we all know it came out in 2010. The modulator thought process and using of medications but it was only a small cohort. It wasn't until 2019, 2020 that most patients were eligible for this. So this was a small cohort. So in conclusion, we know that current day hemoptysis, any degree, whether it be mild, moderate, or massive, or questionable massive, has not been eradicated in the era of highly effective modulator therapy. It is still present. The incident is going down for sure, but we have to know what to do with it and how to treat it. We do know that the estimated reduced incidence of hemoptysis is definitely related to the reduction in the tract, cystic fibrosis tract, respiratory tract exacerbation, and also patients with improving lung function, all attributed to HEMT therapy. So that is why we believe the incidence is going down in hemoptysis, but not gone completely. I'd like to emphasize that bronchial artery embolization remains the mainstay of therapy and treatment, and it has excellent results overall at a specialized center. But I also have told you that even in the era of hemp therapy, recurrence is common. It's quite common, but we need more evidence to really look at it and say, well, these papers were coming from 1998, 2005, 2016, without a significant proportion of the population on these really great therapies. And therefore, my final line, thinking about innovation in the future, is that we definitely need more research that is needed in the area of hemp to really understand the reduction in the risk of hemoptysis and also the need for recurrent hemoptysis and recurrent bronchial embolization. Thank you very much for your time.